I was delighted to hear the award given to Dr. Sue Hewson. She inspired not only Gareth Evans and Ross Ferner and so many people, but she trained everything that I know about NF1 and filled me with enthusiasm for the subject. And I hope that I continue to pay homage to her legacy. I certainly try to do that very hard. So I am not only the pediatric neurologist for our Complex NF1 service in Manchester, but also for the NF2 service. So I'll start with NF1 because that is a bit more complicated, I think. I'm not sure about the audience mix, but I think there are lots of people from Europe and then quite a few people from England. Can I just get a show of hands from the English people, if you don't mind? Okay, so a nice healthy mix, 50-50 about, I think. So some of this may be of interest to the non-English people, and some may not be of interest, but I think it's always very valuable to see how other people do things, just in case something would be useful for your own service. Okay, so I'll give a bit about the background of the Complex NF1. This was commissioned in 2009, and Dr. Hewson was one of the key people that set up the specialist services. And the aim was to centralize and concentrate expertise with international links, and the ultimate aim clinically was to reduce mortality and morbidity from MPNST and morbidity from all the other complications. When you're planning a service, what you have to keep into mind is how many patients you have that are affected and the resources you have. There is no other way to look at it. There aren't infinite resources, and there isn't an unknown number of patients. And so the clinicians, the experts at the time, as I said, Prof. Ferner, Dr. Sue Hewson and Professor Gareth Evans, in conjunction with NHS England, looked into the literature and knew that the birth incidence of NF1 was around 1 in 2,000 or 1 in 2,600, depending on the studies that had been undertaken, with a prevalence of 1 in 4,000. Now, with the population in England being 50.7 million, this was estimated as having a population in England of NF1 of 11,267. And it was estimated that each complex centre in England, of which there are 2, would receive about 130 referrals per year between the 2 HSS centres. In fact, we have much more than that. These are the numbers that are quoted in the document with NHS England and are freely available on the internet. Okay, so one of the things that people who are not from England often ask, but I think perhaps it is also not clear to the English population, because these things are incredibly complex, is how does one with NF1 who needs a specialist service get access to the service? And this is a slide. Now, I live in Oldham, as Sue will tell you. She tells me you live too far away, to be practical. And in fact, it took me 2 hours to get here today. I use a slide from Oldham. So these are the terraced houses. As you can imagine, an old mill city like Oldham would have. This is one of the community centres, which are GP practices where community paediatricians practice. Those are secondary levels. Then if they're very poorly, the children, and they need acute services, they would go to their district general hospital, and that's the Royal Oldham Hospital, where my second daughter was born. Then, if the children are even poorlier and the district general hospitals can't cater for them, they refer them to the tertiary centres, and that is the Children's Hospital, where I work as a paediatric neurologist. And then, if they are even poorlier than that, they get to the level 4, which are the specialist centres. And NF1 is not the only highly specialist service in England. There are plenty. So, for example, we have a neuromuscular specialist service, we have a Batten's specialist service, we have bone metabolism specialist service, we have countless specialist services. They are very often very rare and very difficult conditions that require really concentrated expertise. So, as the child moves according to the trajectory, what you will see is that the number of services available to the child or to the adult changes starts off with GPs, walking centres and A&Es in their hundreds and thousands all over England. But then in the secondary care you get thousands, the GHs, tertiary hospitals you get hundreds, and then for NF1 there are 2 specialist centres. And as the severity of the condition worsens, the number of centres decreases, but the point is that those 2 centres have all the necessary expertise needed to deal with those complications. Okay, so I tried to put some of the specialists that we have in one of our specialist services, and credit to this, I think, goes to Dr. Sue Hewson. I think since she's retired, I've only added 2 or 3 other consultants, and it always fascinates me how wonderful the people she has chosen for the specialist centre in Manchester. They are incredibly nice, very committed people, extremely clever, and we work very well as a team. So Sue, that's another credit to you, I think. You really chose well. I'm not joking, you know, it works very, very well. And I think one of my introductions tomorrow is going to be, you don't just need brains in NF1, you need a heart as well. So I think every clinician has to have brains, but has to have their heart pointing and aiming at the ultimate goal of looking after patients. And I think Sue has chosen very well. I have chosen another 2 or 3, and I think you would approve, Sue. Okay, so there are plenty of people, okay? Neurosurgeons, adult and pediatric, spinal surgeons, plastic surgery, oncology, both adult and pediatric, ophthalmology, neuropsychiatry, respiratory physicians. We need specialist scanners, we need plastic surgeons, we need sarcoma units, and we need craniofacial units and orthopedic units. And those are not all the people you need. These are the most common ones we need. And we rely on the goodwill of our colleagues, so that when we need services that we don't commission directly, they still tell us yes, because the hospital serves the specialist services. So I think we're very lucky to have that. Okay, so these are the clinics, and this is Manchester clinics, and these are Guy's and St. Thomas's clinics. And what we have set up, and I think Sue started to do this in Manchester, but I have really expanded and exploded that, is setting up complex clinics, okay? So there is the nephrologist plus an orthopedic surgeon, the nephrologist plus the plastic surgeon, the nephrologist plus the pediatric neurosurgeon. And that way, what's happening is that the patients get a one-stop shop rather than 20 appointments. And also the clinicians learn from each other. So for example, when you have a consult without an orthopedic surgeon, you can at least answer a few basic questions and you can feel competent about that. And the learning curve is wonderful, actually. And the patients really appreciate that. And we have very successful complex clinics that we run on a regular basis to fulfill these aims. Okay, so exclusion criteria and referral criteria, sources and routes. So the national complex NF1 services, they are there, these services, for the medical management of complex manifestations. And it is not there, they are not there, the services for the management of non-complex NF1. Now, the problem is that the dichotomization between complex NF1 and non-complex NF1 is man-made. It's us humans who have done that dichotomization. And so there is the potential for people with NF1 to feel that they are perhaps being deprived of the complex services simply because they do not fulfill the criteria. But the point is that the complex service is there for patients with complex complications. And I will explain a bit more about that. Now, all the referrals we get, and we get many, complex, non-complex, we get non-NF patients, we get patients that are referred to us because the families are anxious that their child might have NF1. We discuss all the referrals in the triage meeting, and we triage them according to need. Okay, So this is one of the things that I feel very strongly about, actually. So I think NF1 is like an iceberg in terms of service provision and need. And the complex services in London and Manchester are commissioned and sourced simply to teach the tip of the iceberg, i.e. the patients with complex complications. However, as we know, there are many patients with NF1 that have ill health, generically, that would benefit from clinicians with expertise to help them along. But they actually do not fulfill the complex criteria. And both services do their utmost best to try and see as many of these non-complex but complex patients as possible. We also know that there are many people with NF1 who are completely well, thank you very much, and don't need us at all. And so, you know, those are always welcome to the service, even when they need it, but they generally don't. Now, the complex criteria are well defined, and they are reviewed regularly. So over the past couple of years, we have added a couple. We've added aqueduct stenosis, and we've added neurovascular disease like moya. And so it doesn't mean that the complex criteria have been written in stone like the 10 Commandments and they never change. They change according to what we see as clinicians there is a need to change to. And I think this is really important because I really insisted on the moyas being inserted because we have many of them. And in fact, because we are a specialist center, the highest number of moyas that we have are precisely in children with NF1. They exceed even those with Down syndrome, and that is because we are a specialist center. So that is what I've just said here now. And the ultimate aim, as we all know, is to reduce the morbidity and the mortality of people with NF1. Okay, so these are the latest figures of both our services. And you will see that London is a much bigger centre than Manchester. Obviously, the south is more densely populated and they are more resourced. But also, historically, the services were set up differently. So the London centre is based in neurology, whereas the Manchester centre is based in genetics. And that has led to differences in funding streams. But what is important to note that the number of complex patients is roughly the same, considering the population and the allocation of resources, and that also the number of complex patients far exceed any of the commissioning figures that had been originally set out in 2009 when the services were constructed, and they have not been reviewed since. Okay, now all of you will know people affected by NF1, perhaps even some of you that are affected by NF2 may know about Selumetinib, and Selumetinib is a MEK inhibitor, and we are hopeful that it may change the trajectory of people's lives, particularly people who are affected with significant plexiform disease, but perhaps even more so with other complications such as low-grade gliomas, and we'll be talking more about that throughout the conference. In reality, what Selumetinib has done in terms of management of the service and allocation of resources, it has given us a challenge of creating a new service within a service. Okay, this did not exist when the services were established, and it is now just been approved by NICE, and both services need to create a new service within a service. There are significant problems with resources, and the resources are not just financial. Now, I really would like to emphasize this point. It is not just about money. It is also about expertise and finding the right people. So I've just been saying, Sue managed to create a magnificent team because she had hunted and found the right people. Not only is it sometimes very difficult to find the right people, but sometimes it is difficult to find any people at all. So I need a second adult neurologist for the service, and this I am going to advertise for the 4th time. Okay, 4th time. Not even one applicant. There is a huge national shortage of adult neurologists. So sometimes it's not just about the money, because patients think it's about money, it's about money. It's not just about money, it's about finding the right people and people who are interested in you, because you don't want just any person, you want someone who's interested, yeah? So that's the thing, that's the resource issues. Now, what Selumetinib has done, it has challenged us to find different people as well. So, for some reason, Selumetinib is prescribed by oncologists, and I'm not going to get into that at all. All over the world, it is prescribed by oncologists, but it is actually not a chemotherapeutic agent. Yeah? And so you have to establish new bridges with the oncology department, ask them to increase their workload, ask them to start interacting more closely with you, and building this new service within a service. In addition, as you know, one of the worst side effects of Selumetinib is skin complications. So all of a sudden I had to find an interested dermatologist as well. And we have, luckily, an excellent academic dermatologist who has started to join us. And I'm very proud to say that we have the first in the country MEC MDT clinic. So there's myself, there's Professor J.P. Kildare, who is an oncologist, and there is Dr. Helen Young, who is a dermatologist, as well as the specialist nurses. Even to set up that clinic, it's taken me about 3 years, because as soon as I got the first wind of the paper, I started work, because you can see where it's going, can't you? You have to start. And we still don't have a finalized pathway. We are still negotiating with oncologists and oncology units throughout the country, and working with NHS England to formalize the pathway. But work is progressing. The other thing that I feel passionate about is we should have equitable care across England. To me, it shouldn't matter whether you live in Manchester, or whether you live in Glasgow, or whether you live in Oxford, or whether you live in Cornwall. You know, this is a country, and people should have access to their specialist services. It's easier said than done, but that is something that I'm passionate about, and that is something that we work steadily to try and achieve. And that's just the care, okay? We have to be thinking about research. We have to start to learn more about these drugs and when best to use them. So there's also not just the care pathway, there's also the research pathway, both of which are incredibly important. Okay, now, nothing is perfect in life, okay? However, personally, perhaps because I'm a pediatrician, I think that the pediatric pathway is much more robust in England than the adult pathway. And I will explain a bit why I think this is happening. Now, we are fortunate in pediatrics, and as you know, Selumetinib is licensed for children, okay? It's not licensed for adults yet. I think that will come, but at the moment, it is licensed for children. And perhaps we are in a very privileged position as pediatricians to establish a pathway that the adults can follow. So I don't know, many of you will know about stroke, for example, yeah? So can I ask you, where do you think the stroke services are most robust, in adults or in children? Adults, exactly. So what happens when a child comes in with a stroke in England at 3 o'clock in the morning? Very difficult, okay? Again, people scrambling to help each other. Why? Because the stroke pathways for children are not established. So what we are doing is we are trying to emulate the adult stroke pathways. We are working internationally, and we are starting to establish pediatric stroke pathways even in Manchester. And what I anticipate is that the reverse will happen with Selumetinib. The pediatricians will set up the pathway, and then the adults hopefully will find it useful. So in pediatrics, everything is very robust. There are pediatricians. They're either based in the district general hospitals, these are secondary level, or else in the community. There are oncologists, all of whom are based in the tertiary centres. and we all interact very well together, including the tertiary service for complex NF1. And we have many examples where this has worked, and children have done very well on MEK inhibitors, initially on compassionate grounds, some on a study, and now hopefully across a pathway that we will come to an agreement with. Now, the vision for Selumetinib is that the patients will be referred to the 2 centers, they will be discussed through their own MDTs, and then the children will be put forward to the national MEK inhibitor MDT, and then they either fulfill the criteria or they don't, and then a local hub and spoke model pathway will be offered to the child, and the child will receive the medication that they need. The pathway is still in evolution, but progress is good. Okay, now I mentioned that whereas in pediatrics, I think, it's not perfect, nothing's perfect, but it works and I think it's robust. I think the challenges in adults are greater. And this is my theory, but I think that this has happened because the secondary level care, i.e. in DGHs in adults, has changed over the years. And I can easily say this because my own husband is a physician. He's a general physician. And he started his career looking after all the medical patients, being a consultant in all the medical patients, and then over the years developed an interest in Parkinson's and stroke. And he is now a stroke physician. And what's happened over the years is that physicians are all with a special interest, okay? So you get a physician with an interest in stroke, a physician with an interest in Parkinson, a physician with an interest in cardiac, a physician with an interest in gastroenterology. And what has happened then is that people are becoming specialized, and there isn't a general physician that is interested in the general health of any individual that walks through the doors. And that has happened very slowly over the years. And what this means then, that it is almost always impossible to find an adult physician for a patient with NF1. You have to find a neurologist who's interested in that patient, or a neurosurgeon, or a gastroenterologist, depending on what the primary problem is. And that has led to problems. These can refer to the tertiary services and the complex service, but it is not as robust, and we see this again and again. So what results, I think, for the adults is that sometimes the services can become fragmented. Is this irreversible? No. There are some hospitals where we have managed to find physicians who will take a special interest in people with NF1. And we have good examples of that, which we have published. And for example, in Leeds, a consultant geneticist, a young consultant geneticist with a PhD in cancer genetics, has actually become one of the strongest hubs we have in the north of England. In Sheffield, again, we have 2 adults that we can depend on, an adult neurologist and an adult neurosurgeon, and they are really good links. But it is, it takes work to find these individuals, and you really have to work at it. What's really important is that you help them back, yeah? So it's important to network. It's not just about, we need you. We need you, and you need us, and we're there for each other. It's that networking of management that is so important. So moving forward, I think what we need to develop is finding physicians at secondary and tertiary hospitals that will take an interest in NF1. Not easy, but it is possible. So I don't know, are there any Italians here? Yeah. So I'm not Italian, okay, I'm Maltese, but I do speak Italian. And my father used to tell me this, fra il dire o il fare c'è un gran bel mare. Do you recognize that proverb? Yeah. And what it's saying there is that between the saying and the doing, there is a sea. There is or an ocean. Yeah? Because many people are good at this, yeah, but not good in the muscle when it comes to work, okay? And so it's all very well for me staying here, but actually I back that with a lot of work. And I think as a parent group, as a patient group, your influence in this is very important. If you see your clinician and district general, tell them, do you find it interesting? Do you know anyone who's interested in NF1? It's about working together and creating opportunities, because there is a big ocean between saying and doing. Okay. Now, this is the North-South divide. For the Europeans, there is no doubt that the south of England is much richer than the north of England. Okay, there is absolutely no doubt. Besides that, the public transport network in the south of England is much more efficient. Okay, so you have two things. You have a poorer population in the north, and you have a more difficult transport mechanism in the north. So, as you can imagine, for me particularly, this is a huge challenge, because I would like my patient in, Newcastle, to be able to get exactly the same service as a patient from Oxford would, okay? But the reality is that they are completely different in access. One way of circumventing this is actually with the creation of satellites. Now, Sue started this, and we continue to build, but times have changed, and the NHS linkages have changed, and the resources have changed, and the people who are interested in NF1 have retired. And so we've had to find new ones and create new links. And this is not easy, but as I said, it is possible. And the proof of the pudding comes in the eating. And we published a poster that we presented at CTF a few months ago, where we proved actually that a hub and spoke model with big tertiary hospitals can work extremely well. And we have loads of clinics in Leeds now. Dr. John Ealing, our adult neurologist, I think does 6 a year now. I do 2 huge neuro-oncology ones. In fact, they are 4 actually. And I do also 4 with the geneticists. So real good, heavy-going clinics with the most complex of patients. And you tell me, well, why do you bother, Grace? Why? They can easily travel to Manchester. But that's not the point, you see. What happens when you create good links with a good tertiary hospital? Well, if you are suddenly admitted at 3 o'clock in the morning in Leeds, nobody can say, well, we know nothing about NF, we know nothing about you, we can't really help you very well. Why? Because those patients are known to Leeds. When they are admitted to the Leeds General Hospital, then they feel confident because this is their tertiary hospital. The clinicians have access to records. The people feel empowered. Also, what does it mean for us when we're trying to establish pathways for children to get MEK inhibitors? Well, we have links with the oncologists already, you see. So they're there. I do clinics with them. They're not going to say, no, I don't want to give patients MEK inhibitors. In fact, they don't. Why? Because we work as a team together. And so it's a reciprocal beneficiary on both sides. So I think these complex clinics are really important, and they can work very well. And in fact, the second child that we ever put on MEK inhibitors came from Leeds. And now there are several. And he is still on MEK inhibitors and doing very well. Okay, so NF2 is completely different. And the reason for that is that it is much rarer. And so NHS England didn't have to say, listen, I have this much resources, we have this much complex patients, this is what I can cater for. For NF2, there were much fewer patients, and all the patients could be seen within the single service. There are also very few completely well individuals with NF2. We do have milder phenotypes, that's true, but that is the exception, not the rule. So the numbers are much less, and all the NF2 patients are served by the HSS service. And they envisaged all the complications of hub and spoke models and actually commissioned for them at the inception of the service. So they are in a much better position. Okay, so Gareth Evans circled. I think he's a bit proud, Gareth, that he covers such a huge area. So he circled this morning. I sent him the slides to make sure he's happy with them. And he circled all the coverage of Manchester. So I thought that was very sweet, bless him. So there are 4 HSS services: London, Oxford, Manchester and Cambridge. And they have established hubs. They do clinics regularly in Newcastle, Birmingham, Liverpool. And obviously the south then covers Plymouth, Bristol and Southampton, and Sheffield we do as well. So much more robust. All care for NF2 is coordinated by the 4 centres. All vestibular schwannoma surgery and other treatment is overseen by the 4 centres. Avastin treatments have revolutionized care and improved survival and quality of life. And Gareth presented this data a couple of years ago, I think, to NHS England, who did one of their spot checks. And when you see his data, with Avastin and with the centres, they have really changed the quality of life and trajectory of patients with NF2. You know, the survival has improved, the quality of life has improved significantly. I think with NF1 we are really lagging behind. Hopefully Selumetinib and the newer drugs will also result in the spectacular improvement that the population with NF2 has seen. And brainstem implants occur only in 2 centres. They will accept referrals from any clinician, just what we do. Specialist nurse. Service covers all ages, okay, so there's a pediatric arm, and I'm the neurologist for that. There's a graded transition, so we see maybe 2 or 3, an adolescent 2 or 3 times before they are fully transitioned, and then there is the adult arm. And the MDT, if it's possible, is even huger than NF1 for the simple reason that they have a lot of base of skull surgeons, because a lot of their work is base of skull surgery. And they have a lot of input from ENT and audiology, which is, as you know, one of the big hallmarks of NF2.